We're here to talk about DTR. And people often ask what we do that's different from other TMD specialists. And what say you, Dr.
Well, we
Kerstein?
don't need appliances, which is a huge advantage for the patient. And because of that, treatment is rapid. And there is not this Band-Aid approach to the problem. So essentially, we treat it directly at its core, at the true genesis, as you've stated, that word, which is really the friction and the bite. And by treating it directly, we speed up treatment rapidly. And results are very rapid. Within the first 30 days, people are very different. So we bypass completely the splints phase.
But to be clear, this needs to be a patient that's suffering primarily from a muscular TMD issue.
Yes.
Right?
Yes.
So there are such individuals that have a joint problem, but that's only about 15%.
10 to 15%.
Right. So we can essentially help probably 85-ish% of the people that claim they have a TMJ problem.
Yes.
That's fair, right?
Without using a splint.
Right. And in my experience, most of the people that find their way to my door, they've been in the splints. The splints didn't do much for them.
Yes, that's very common.
So
Almost every person I see who has TMJ problems has had one or more splints made. They diligently wear their appliance. They comply as best they can, which is frequent use.
right.
But it doesn't treat their problem because their true underlying problem hasn't been addressed.
Right.
And the splint only acts as a partial Band-Aid.
Right. We're often asked how many appointments DTR takes, DTR treatment. In my office, we typically see them in a diagnostic appointment, and then we'll have them back the following day to do most of the treatment itself, which takes about an hour. And then on occasion, we'll have them back a third time, but that's kind of rare. Typically, two visits is what I typically do.
Yes.
You about the same?
2 visits, the diagnostic visit being separate, but treatment visits at day 1 and then a short follow-up afterwards. I tend to try for day 1 to day 7, certainly day 5 to day 7, because a lot of the initial relaxation occurs by the 3rd day.
Mm-hmm.
So it's good to see them after the 3rd day. And then we also may have a 1-month follow-up, sort of 30 days later, to make sure that there's continued healing and that things are headed in the right direction.
And to be clear, not everybody responds immediately. Like some of the videos that we've posted online, it's like they're fixed right then and there. The reality is probably, I'd say in my experience, 30% take time to respond.
Yes.
Before it's profound. I would say up to a month.
Yes, there's rapid early response and improvement that's noted by most patients, but some
On
have
the
a
initial treatment
slower,
day.
yes, on the initial
Yeah.
treatment day. So there's a certain awareness, definitive awareness that things are changing.
Right.
But true healing for some patients can take, up to 60 to 90 days. So what we look for in the first 7 days is that there's been a change in the condition of the problem. It may not be gone, but an example would be if someone is having 7 days a week, they're having headaches, that when they come back at day 7, they have had only a few headaches.
Perfect.
No headaches?
Not that I can recall. I think it was about 3 or 4 weeks ago we had that done, and nothing.
Zero
Through
headaches.
traveling, and usually that's one of the good keys, sitting on a plane for a long time. Usually I get one after that.
Zero,
Nothing.
okay.
Yep.
Right.
And they weren't as bad.
So it's
That kind
it's an improvement. It's not necessarily profound and immediate, though many are, but it just takes time.
Yes, many are profound and immediate.
Yeah.
And it's actually more frequent that there's a profound and immediate change.
That's what I see too.
But there are people that their muscles are highly injured, they're filled with lactic acid, they're slow to heal, their metabolism may be slow,
Right.
their fibers are damaged from years of being bathed in lactic acid, and they're not like elastic anymore, they're like steel wool muscle fibers, and so they are slower to regain normal physiology. And there is no way to know that when you treat someone.
Yeah, you just have to do it and see.
Yes, it isn't about how painful the condition is or how life-involving the condition is. The healing response is solely within the realm of the person's healing capability, and that may be faster for some and slower for others.
There are screening tools that we use, you know, aside from questions. I mean, the ice water swish, for instance, most TMD people have a true aversion. They have hypersensitive teeth, resultant of the muscle pushing the tooth too hard, basically. And that's a very good indicator in my experience. A lot of the myalgic muscle-related type of questions, when they respond positively, like they can't chew gum, or they can't chew a steak real well, they get tired and fatigued. You know, those are positive indicators of a muscular disorder. And then oftentimes we'll image the joints with 3D imaging, and we'll use joint vibration analysis on most patients, because we want to rule out a capsular issue, and we want a stable and adapted joint, theoretically. But there have been times where I've worked on people, performed DTR on joints that are not stable and not adapted, and they improved.
Yes.
So that's, I mean, that's a little sketchy there. It's pushing the envelope, but basically relax the lateral pterygoid, which is the muscle that pulls on cartilage, and things tend to not fall down that slippery slope, in my experience.
Well, the lateral pterygoid, the muscle that controls the disc function, is affected by the friction in the bite.
Right.
And it's such a small
Directly.
muscle. Directly, as with the other muscles.
Yeah.
So it's such a small muscle that it would tighten and stiffen and distort the disc placement very easily. And so when disclusion time reduction is performed, it can loosen that rigid grasp on the
Sure.
disc and allow it to move to a better location within the TM joint itself. And that's why clicking and popping often goes down. That's why people can have increased range of motion right away. And certain disc conditions may not respond, but most of the time, disclusion time reduction is not deleterious to joint structure. So it usually has a profound positive effect as well.
You know, another thing I noticed, most people, most dentists don't even understand this, but for one to have a capsular issue, a joint issue, the lateral pterygoid muscle was probably responsible, most likely responsible for that damage.
That's true.
So through DTR, and this is key, we can control the muscles, we can calm them down. And that's something that a splint can't do, physiologically, for sure. And I'm not saying splints don't work, I'm not saying they're never indicated, but it's like you said earlier, it's a Band-Aid.
They only put a barrier between the teeth for some time, and because it's not enough time, the teeth still hypercontract.
Who's going to wear that hard acrylic splint throughout their life, eating their meals, going out in social events, going to school? They're not going to do it. So
Going
as
on
soon as
dates.
they take it out, right? Yeah, that's pretty sexy.
Can't see a 28-year-old TMJ sufferer taking out a splint to have a dinner date with a new boyfriend. It's just never going to happen.
It's not going to happen.
Right. And so the reality is that people put their teeth together thousands of times a day, and a splint can only limit that to some degree. And so when the teeth
You have to take it out to eat.
Take it out to eat.
As soon as you take it out to eat, there's the friction.
Right.
The friction is the genesis of the problem.
Yes.
The excess rubbing makes the muscles work harder.
And
Get rid of the rub, get rid of the contraction.
And that can't be stopped by the piece of plastic.
Yeah. A lot of times we'll get approached with people that have ear issues, tinnitus and a tightness around their joint, around their ear. What's your experience with that? In my experience, the ear thing is a little problematic. I worry when they come in and that's their chief complaint.
Well, if the complaint is earaches, and they've certainly had their ears checked and they've had,
By the ENT.
there's no organic disease, it's very possible that their earaches are lateral pterygoid spasm creating pain,
Right.
which often improves greatly when the disclusion time reduction is performed. Tinnitus is a little harder to get resolution from disclusion time reduction therapy. It doesn't always help it. I would say it's 50-50 that it might help it.
Yeah.
So if patients are advised that it may not help them and they still want to go through it, they're choosing to go through it for the sake of hoping to lessen the tinnitus. But there isn't a way to know, as would, let's say, getting tired, chewing. That's something that responds very readily to disclusion time reduction.
Sure.
Because that's a true muscular issue, as opposed to tinnitus, which is very hard to qualify
More
where it
neurological.
came from.
Vascular, something, yeah. We are also often asked if DTR will cure someone's TMJ problem. My experience, it needs to be muscular. which most are, as we alluded to earlier. About 85% of TMD issues are muscular in origin. Relax the muscle through DTR, and it tends to improve things greatly.
Yes.
Do we agree?
Yes, but
Your
curative is a relative term because we can't turn off the mechanism that causes the problem. We can only turn it down.
Right.
Because teeth still strike, periodontal ligaments still get compressed. It's just drastically far less frequency, and therefore the lactic acid is cleared much more readily, and muscle contractions take place far less. But people still bite down, people still swallow, people still rub their teeth together, and so there's a response, a neuromuscular response that comes from every time people put their teeth together that is not going to go away.
Right.
So the degree of healing really is how low can we get that response to be from the person. And fortunately, most of the time it's a tremendous improvement. But there are people that still have a low-level condition that they're just highly susceptible to their bite and it can't totally go away. Unfortunately, there is no way to know before treating someone. It has to be done, meaning disclusion time reduction has to be performed to see what level someone's going to reach.
Yeah.
And statistically, it's a dramatic improvement for most patients. I would say 85 to 90% of the patients live without an appliance and have dramatically
Which
less
coincides
symptoms.
with about 85% of the TMD people that have muscular disorders in the first place. So I'd
Yes.
say it's fair to say most muscular TMD patients will respond
Yes,
in a very positive manner. That's safe
and
to
in a
say.
short period of time,
Right. And it's lasting.
and without wearing a splint.
Longitudinal studies show it's lasting.
Yes.
Right.
There was a study I published in 1995. There was a 9-year recall study of 102 patients, and
Statistically
speaking, they all lived with far less symptoms, took far less medication.
At year 9.
At year 9, used many less splints, didn't need splints, most of them, had very few recurrent symptoms,
Yeah.
went from chronic headache conditions to isolated headache conditions. Medications they took, they used very infrequently.
So a definite improvement.
Yes,
Yeah.
and a lasting improvement.
Right. That's awesome. We're often asked if the bite adjustment will hurt their teeth, the patient, their teeth. Will the occlusal adjustment hurt anything? And there's lots of criticism that comes out of that. In my experience, I'm removing 50 microns maybe on 4 or 5 teeth in the back, in an average case, and I'm adding a little bit of bonding, white filling material to a couple of the canines on a typical case. What do you say? What's your experience?
It's very rare for a person to have deleterious consequences from having their teeth adjustment done in the ICAGD method.
Right.
Other methods, I can't say. Equilibration, I can't speak to.
And this is not equilibration, we need to make that clear.
Right, it's not
Totally
equilibration. Equilibration is a operator-controlled jaw manipulation procedure which does not treat the friction in the bite. It equalizes the centric relation, centric occlusion discrepancy, and it increases molar contact and lessens anterior tooth contact. And that is counter to what ICAGD does. ICAGD, which is the adjustment process for disclusion time reduction, lessens molar contact, increases anterior tooth contact,
Yep.
and does not create deleterious side effects.
And it's not iatrogenic. In other words, the dentist isn't performing a movement. The patient's own muscles are taking them to where the muscle wants to go.
But it's not operator assisted.
So this is natural.
Right, it's a patient who controls all the movements themselves.
And that's huge, huge difference in my book between equilibration. That's the biggest difference between equilibration and ICAGD, which is how we perform DTR. We are doing something very natural, whereas the people who are doing equilibration are doing something what I consider relatively unnatural. I do believe we go into centric relation, just like a range of motion with any part of our body, but not to the point where that's where we need to be biting.
Yes, it's not a functional position.
Right, that's like a border position.
Correct, it's a border position.
So,
And a border position may be reached periodically, isolated at best,
Right.
but maximum intercuspation and right around maximum intercuspation is reached thousands of times a day by the patient.
right. We are often asked if DTR treatment hurts. What do you think?
The only people it really hurts are people that have already ground their teeth into the inner tooth structure and don't have enough enamel to go through it.
Into the dentin.
Into the dentin. And we generally, speaking for myself, and I'm assuming for you also, we don't really treat those cases with coronoplasty or ICAGD because it's not possible to do. So there becomes an additive case or a prosthetic patient who needs the same occlusal endpoint, the same short disclusion, the same lack of friction, the same anterior tooth controls, but it can't be obtained through reshaping the teeth. It has to be obtained prosthodontically.
Additive procedures.
Or additively.
Add instead of subtract. So that's another confusing point amongst patients and other dentists and whoever's interested. A lot of times I'll hear, you're just grinding on teeth. We're not doing that. Oftentimes we're adding.
Yes.
And the grinding, this is key, the grinding that we're doing is typically on other dental work, on other restorative work, fillings, crowns. Orthodontic tipping, the orthodontist never quantified the end results. He never put a number to how balanced the bite was in the end. Because it's all about the way that little tooth sits in space, that machine part, I call teeth parts of the machine. And if that part of the machine doesn't sync with the rest of it, the timing makes sense, can be off. And so we're talking about shape, timing, friction. It aggravates me, to be honest, because what we're grinding on is typically something that was placed there artificially by the other dentist.
Well, many times there is a dental procedure, a dental material that's sort of breaks the camel's back and becomes the causative agent of why there is
in the eyes of the patient.
In the eyes of the patient. And I had this filling done, and ever since then I've had TMJ. I had 2 crowns made. My dentist adjusted my bite, and since then I haven't been able to get comfortable, and now I have headaches and facial pain. That certainly happens a lot. But there's also the orthodontic patient who has no fillings and no crowns and perfectly healthy teeth, and they develop TMJ. And then there's the non-orthodontic patient who has beautiful bite, looks fine, visually, teeth all line up, and they have TMJ.
Yep.
So the
Well,
basic...
what about that patient that loses the first molar and the second molar behind it tips, and all of a sudden introduces a bend in the machine part that throws the timing off?
Yes, the same. It increases the friction. The tooth position changes and worsens the friction.
And that may have happened 20 years ago, and they're just now becoming symptomatic.
Yes.
That's my experience.
The evolution of the problem can be slow in some people and faster in other people.
Right.
But the amount of correction, whether it's on a dental prosthesis, such as a crown, or a natural tooth, when the canines make contact, when there's normal amounts of enamel, is negligible. And that is not to minimize that tooth structure is being treated. And I say this to the patients, the amount of tooth structure that's taken away is at a minimum if the front teeth contact, yet it's a necessary amount of tooth structure to take away in order to achieve the physiologic healing. And
the reason we're doing this is because it's been proven in research repeatedly that this timing, you make the bite more efficient when you're grinding around and chewing your food. Basically, the central nervous system is happier with the end result.
Yes,
by not working so hard.
The research shows that the shorter the disclusion time, the lower the amount of muscle activity that's used to move the mandible through the actions of chewing, clenching and grinding, swallowing, and that creates a system that does not incite a lot of lactic acid, which then does not pool in the muscles and create the symptoms. So the amount of time is directly related to the amount of muscle activity, and the frictional time is only measurable with the T-scan.
I tell a lot of my patients that it's almost like you have a car that gets 20 miles to the gallon, and then you align the vehicle, the engine part, whatever, the frame, that's immaterial. The point is, you do something to improve the efficiency of the vehicle, and all of a sudden you have a vehicle that will go 40 miles to the gallon. It just makes it more efficient. The engine doesn't have to work as hard. It uses less energy.
Much less energy.
Much less energy. So when the muscles aren't firing as much, they start relaxing more. They do their job and shut down. Whereas the muscular TMD patient, it never shuts down. When it never shuts down, it gets wore out.
Yes.
In the patient's eyes. The muscles become ischemic, right, without oxygen. And then we get into biochemistry we don't want to necessarily talk about. But as you said, the lactic acid, just like when we work out too hard. We're sore for a few days. But if we keep working that muscle out, we never get it a chance to dissipate. So we feel bad. And that's the genesis of most of these TMD issues.
Yes.
The pain from the muscle that is always tight and contracted.
Yes, a very common thing people say is they feel tension and tightness in their face.
Yeah.
Never goes away. They try to relax it by stretching it out, by doing exercises, by rubbing it. But the only thing that can take the relaxation to the natural state
Right.
is by treating the
genesis.
friction in the teeth.
Cause.
Right.
And the neatest thing, in my experience, is probably 95% of the time when I'm an hour into DTR or just about finished with somebody, I'll ask them how their face feels.
Face, what's it feel like?
Just not tense.
Loose, right?
Wow. Relaxed.
Relaxed? Yeah. The whole face, the temple?
That right in here.
And the answer is relaxed.
Yes.
Like profoundly so. They're half asleep from this. They feel like they just had a massage. The
Yes.
muscles are releasing.
The lactic acid is leaving,
It's amazing.
oxygenation is happening,
Yep.
right? And people are very aware of that. And that happens in a lot of patients, not 100% of patients. That can be slowed in some patients,
Yeah.
but often, I would say more often than where it doesn't happen.
95 is a little high. Probably more like 80%.
Yeah.
I hear it that day.
Yes.
That's fair. Okay, we are oftentimes asked if the patient has to get numbed for DTR. In my experience, absolutely not. The worst thing they feel is a little bit of cold sensitivity when we first start, and that typically abates. Cold from the room temperature water coming out of the drill. You see
Yes,
anything like that?
it's rarely needed to anesthetize someone.
Yeah.
But if someone is borderline exposed dentin, they have enough enamel to do the procedure, but you can see exposed dentin, they'll often be more sensitive than the patient who has completely intact enamel.
Sure.
So those patients can sometimes benefit from small amount of anesthesia. But one of the reasons I try not to give people anesthesia is I want to know where on the teeth it does bother them to have
Oh, yeah.
some reshaping done.
That's an indication, in my experience, of a tooth that's taking too much load.
Can be, no question. And as someone doing the process, if you have a upper tooth that's sensitive, you can adjust the counterpart on the bottom in the same
Sure.
place and not, create that irritation. So being anesthetized would limit that patient's response.
Yeah, I can't think of a single patient I've ever numbed up.
For
DTR.
I would say
Maybe one.
There's one person that I had to anesthetize many years ago.
Rare.
But it's rare, very rare.
Yeah. We are often asked if insurance will cover DTR.
No,
No. Sorry.
right.
It doesn't exist in the eyes of the insurance company.
Patients can expect that they will be paying out of pocket for this service, and being in pain, usually they want to have it done, regardless of whether there's coverage or not.
But this is not, by definition, in my mind, based on the CDT codes, a complete occlusal adjustment or a limited one. This is far more detailed. It's timed. It's very precise.
It's much different in terms of the
Hugely
quality of
different.
the procedure.
Yeah, they're always talking about
Right.
transferring casts, articulators. We're doing this in the mouth in the physiologic place where it belongs. Totally different thing.
With computer guidance.
Right. Timing and everything. I mean, it's absolutely amazing. The precision.
So patients can expect that they won't have coverage, and that shouldn't hinder them from going through the process. If you're not in so much pain, you might want to fight with your insurance company, but most people are readily willing to assume the cost because they're not getting rid of their problem with all the palliative measures and with all the splints and with all the non-disclusion time reduction treatments that they go through.
Typical patient I see has been through 2 or 3 splints. They've already spent well over $5,000 on average.
Correct.
Yep.
And they still have the problem.
Yep. Or they wouldn't be there.
It's been shown to thousands of dentists
And most are resistant.
and thousands of educators.
Yep.
All the big names have seen and read about disclusion time reduction, but none of them have taken to it.
Yeah, we should talk about that for a minute because it's absolutely ludicrous in my eyes. I mean, it works effectively. The videos alone, as of October 2014, I have about 50 case studies, 50 different patients that are profoundly affected. And these are not stories and they're not artificial. And yet, the patients get it, but the dentists refute it. They think it's bunk. And you've been publishing about this for 30 years?
Yes,
Statistically, you're showing proof.
scientifically.
Right, and visually, I'm showing via videography profound changes.
Yes.
So what's wrong with this picture? Because we know it works 85% of the time.
The educators don't want to teach it to the students
Because they have probably some political or financial interest.
because they're not the ones who developed it. They're not
Could
the
be.
ones who are using the T-scan. Many of the leading educators have resisted the T-scan outright and don't teach it at all.
Yeah.
And so how can they adopt a procedure that would be like really
Yeah.
beneficial to the public if they don't believe the technology is beneficial to the public?
Bite ribbon is an analog, archaic metric. You can't quantify anything. The paper's shown what, 12-ish% accurate relative to force and time?
Dentists can look at paper marks and choose them correctly 12% of the time.
Right. Okay.
That
So
means
your dentist.
88% of the time they're choosing them incorrectly.
So they are criticizing us for grinding on back teeth when we know exactly where things don't quite fit in the part of the machine, but yet they are grinding 8-to-1 on the wrong place themselves.
Numerous times.
Right.
The wrong place.
So who really here is doing something that's not conservative?
Oh, T-scan guided occlusal adjusting is minimally invasive, maximally therapeutic. The reverse for by-eye, paper-only adjusting. It's maximally invasive because the dentists are, quote, subjectively interpreting the carbon paper marks,
And they're asking the patient how it feels. That's subjective if ever I've heard of one.
and they're only getting, choosing the correct paper marks 12% of the time.
Nice.
So that's why it's maximally invasive. There's too much guessing, and if the public knew the dentists were guessing, they
Yeah.
wouldn't be very happy about that.
Well, we're trying to let the public know because
Yes.
they need to know.
The public should know the dentists are guessing 88% of the time.
And that's the reason why this works, because we're not guessing. The digital technology is in what, the 92-95%
It's
range?
95% force reproduction accuracy,
The T-scan sensor.
the T-scan sensor.
Versus the ribbon that's 12%, the paper.
No, the ribbon
the
is
bite
the
ribbon.
ribbon is not accurate at all because it doesn't measure anything. But the dentist looking at the ribbon is only 12% accurate.
Right.
If you look at the ribbon alone and try to choose the marks from looking at the spots on the teeth, 88% of the time you'll choose incorrectly.
Yeah.
Which is why people get 2 crowns installed and suddenly they have TMJ, or why they have a few fillings done
Yeah.
and someone grinds a few places and now they have TMJ.
Then there's pain.
Because the dentist is choosing the wrong places, he doesn't know which places to choose based on the principles that are taught about what the paper
Now, he doesn't
marks
know
look
any
like.
better. You know, when he went through dental school, that's the gold standard. That's what they still teach.
Yes,
And they refute the utility of this $10,000 gadget because there's no return on investment. You know, most dentists are small businessmen and they want to turn a profit. They'd rather spend 20 cents on a piece of paper than $10,000 on a handle that shows them what's really going on. Because
and the leaders haven't adopted the T-scan
Right.
in any field, in implantology, in
Orthodontics,
prosthodontics, in
periodontics.
orthodontics, in periodontics, in occlusion, and in TMD, they've resisted the technology.
Yeah.
So the learning dentist who might want to advance and improve is being told, no, you don't need the T-scan, it's not necessary.
How about the cosmetic dentist that drops in 14 veneers and insists that the patient wears a splint? I do
Well-
all kinds of cases like that. I don't make splints.
Yes, I'm a prosthodontist and I don't make
Yeah.
post-insertion splints
There's
at all.
no need if you understand the occlusion, if you quantify it.
Haven't made them at all.
Yeah.
Right? So control over the end result is much greater with measurement technology
Yeah.
and taking the guessing out of it. But the dentists haven't been led down that path. They've been led down the path of you don't need the technology.
Yeah.
Right? And so
We've
that's
gotten-
where these problems
My
arise,
mentor, he made it through his entire career without it. Why do I need it?
essentially.
We're often asked if the electrode leads that people see in the videos are a TENS unit.
No, we don't need tens.
Right.
Right.
Iatrogenic,
They're
artificial.
measuring the muscle activity. Those leads are measuring the muscle activity levels before disclusion time reduction and after disclusion time
Right.
reduction. TENS is an artificial method of relaxing muscles. It's very useful for that, relieving pain. It has a lot of benefits, but it's not a permanent correction.
Right.
So people get tensed and then
It's
their
a temporary
symptoms come
thing.
back.
Right.
Right.
It's like taking an aspirin for a headache. So basically the electrode leads that they see on the videos or that they see in photographs, those don't impart any kind of electrical signal into the body. They only sense electrical activity from the muscle.
Correct.
Right.
They're not imparting any current into the muscle.
They're listening.
They're just, right. And as such, the changes, then we leave the leads on the face from before treatment to after treatment, so we can see that, we did reduce the muscle activity dramatically within the, 45 minutes or hour that it takes to do the procedure.
Proof that we shut the muscle down.
Yes, it's right there on the screen. It happens,
that's amazing too.
right away. And it's the only real quantifiable way to see that muscle activity levels have changed.
What else is interesting is without EMG, before I started using EMG with the T-scan, I would have good results, but not amazing results. When you add EMG, you can prove that the muscle is shut down. So,
Yes.
advice to the patient looking for a dentist who does DTR over time, make sure they're using EMG. I mean, that's a little harsh, but you want to be in the A range, you need the EMG, in my opinion.
No question.
In my
No
opinion.
question.
The
The
T-scan
two-
alone is great, that's awesome, but spend the extra money and the extra knowledge, learn how to use the link itself.
Yes.
We are often asked what the long-term effects are for DTR treatment. Is it lasting? What can they expect?
Yes, it lasts. It lasts extremely well.
Again, the
Same
longitudinal
thing.
studies.
Yes, research shows, not only does the symptoms stay down, but also the disclusion time doesn't change once it's fixed.
Yeah.
And that makes sense because you're trimming the teeth, and so the friction can't grow back. Teeth don't regrow. But if someone has new dental work done, if someone has a tooth extracted, if someone has braces put on their teeth after this is done, not necessarily right away, but somewhere down the road, that
can
can
alter it.
create a new amount of disclusion time, an increased amount of friction, and recreate symptoms.
On a personal note, today we looked at me with the link, and we were looking at me with the T-scan. And you pulled out the old data from 4 years ago when I was DTR'd, and the numbers were almost the same, within
Yes.
about a tenth of a second.
Which is what the research shows, that the disclusion time will lengthen about a tenth of a second.
That's exactly
But
where
if
we
it's-
were.
If it's 1.6 seconds in right excursion pre-treatment and it ends up 0.45, it won't be 3 years later 1.2 seconds.
Right.
It'll be 0.55.
Right.
So-
And that's almost perfectly in line with what I saw today.
Yes.
And the data from this guy right here, this patient.
And there's a study about that too, published in 1994,
Really.
that shows that. 1993, I think, but somewhere in the 90s. That shows that the
So many papers, you've lost count.
that the disclusion time will change in a tenth of a second across time, but not go back to what it was pre-treatment.
Which, that's amazing, because a lot of people want to know how lasting it is. And again, in line with our question.
Yes, it's very lasting, but it doesn't mean people won't have episodes in their life where they might have stress creating clenching and grinding, where they might get some symptoms, they might have a dental procedure.
But
done that
nothing
will
like it
change.
was.
No, nothing like it was.
Right.
It's very interesting. It's, I have patients now 20 plus years out, come in for a cleaning and they're like, yeah, ever since you fixed my bite, I don't have headaches and, I don't need medication anymore. And
Yeah.
it just doesn't happen anymore.
It's amazing.
That's a long time.
What do we tell the patient about neck and shoulder tightness? Will DTR help them with neck and shoulder tightness?
You can tell them it might help them, but they have to have it done to find out. There's
In
no
my experience,
Yeah.
typically yes, but there could be many other reasons. They could have a cervical problem, an atlas problem, a disc problem, gosh knows what. So
And most, let's say realistically, there is no neuroanatomic tie-in to the neck muscles. There's a direct neuroanatomic tie-in between the tooth socket and the muscles of mastication,
Right.
the digastrics, the mylohyoid, some of the muscles in the ear, some of the muscles in the palate. There's no neuroanatomic tie-in to the neck and shoulder muscles.
I think there's some synergy going on though. I think when guys up here are overworking, guys down here, I know this is very barbaric, but I see it all the time. You relax these guys no longer try to help from a distance.
Yes, and that would make sense.
But
And there's no question that a lot of the patients, a lot of them over the years, report, improved neck mobility and less strain and less tension.
Yeah.
But what the real effect is on those muscles is hard to know because
Yeah.
there is no neuroanatomic tie-in. So
We
it
don't
very
know.
well could be compensation. It very well could be electrical fields that are here tightening up these nerve endings that are running through here.
it's all one body.
So, but there is no way to say to someone, you know, if they only had neck problems and they came in and said, you know, my neck, it's always sore and stiff,
I
and my
wouldn't.
face doesn't hurt, my
Right.
head doesn't hurt, I don't have the common symptoms with the neck, it would be strictly elective for the person to choose to have the treatment rendered to try to help their neck, because there
Right.
is no neural.
Kind of a shot in the dark there.
It's hit or miss, no
Yeah.
question.
Yeah.
Whereas if they say, I get tired chewing and my face hurts when I wake up in the morning, you know, that's more likely gonna respond very quickly to the treatment, because there is a direct neuroanatomic tie-in.
Sure. A reason.
As I left the office, that horrible severe pain that I've always had back here was completely gone. When I woke up the next morning, all of my right-sided headache, jaw pain was all completely gone, and I've never had it come back.
Okay, and
Not
that
at
was about 2 months ago.
Mm-hmm.
Can DTR stop clenching and grinding?
Absolutely. Studies show that. Patients report that. It's a very, very common effect.
I've taken dozens of people off splints. More than that. I'm not going to say it always works in my hands and in my experience, but the vast majority of the time, they don't need splints afterwards. I mean, 90+%. And these people have tried everything else. My answer to that is almost 100% yes. It will help. If not completely knock it out.
I would say it's probably certainly above 85% of the people don't need an appliance anymore. And they report things, and this is something I've been hearing for a long time, they sleep better without their appliance, their partner doesn't hear them grinding their teeth anymore, they find during the day their teeth aren't clenched anymore. You know, interesting things, you know, like their husband had to leave the room to sleep, and now they
the couch.
don't have to do that anymore.
Right.
And you know, what would be interesting to do would be a sleep study, you know, where disclusion time reduction is performed, and you know, sleep bruxism is a problem before treatment, and then have it be monitored. But the sleep industry doesn't have interest in the T-scan so far, so that hasn't happened yet. But there's no question, clenching and grinding as a habit goes way down once the disclusion time is changed. And I can't say it's 100%, but it's very strong,
Yeah.
you know, 85 to 90% of the people. And the long-term study that we talked about earlier showed that I think there were, out of the 102 patients that were recalled, 90 plus had pre-treatment splint therapy of some kind.
They no longer use it.
And 87 of those patients didn't need a splint after treatment. So what is 87 out of 92? Almost.
That's
you know,
amazing.
right? So it's something like 90%.
And that's typically an hour-long procedure.
Right.
And it's lasting permanent.
And the instructions to go home the first day are, don't wear your splint.
Yeah, right?
Right? Stop wearing your splint.
Actually, I've seen people drop either splints or old orthodontic retainers in after DTR, and it pulls them back to the problem.
Yes, it worsens because it gives them something to clench on.
We always tell them that, you know, if you're electing to wear a splint, it's not because we're recommending that. That's up to you if you're paranoid. But you need to get a new one made, and orthodontic retainers that may touch the tops of the teeth, cover the top surfaces, that would also need to be remade.
Yes, those new,
That's important.
the new orthodontic retainers, which are the clear,
Yeah, suck
hard
downs.
suck downs, those are horrific to wear
Big
if
time.
you have TMJ problems. Those create the same occlusion, the same incorrectness in the occlusion at a higher vertical dimension, stressing the muscles, giving the same terrible contact pattern that was causing the problem in the first place.
Right.
Right. So those are going to recreate the problem.
They need to make an Essex or a Holly. The old school way is best.
Right, a Holly would be better. A
Oh, for
wrap
sure.
around, no
Yeah.
occlusal interference is absolutely true.
Oh, yeah.
But that's for sure. The person who wears an appliance can have a setback from getting
Dropping
the
the old
physiologic.
appliance back in.
Right, the physiologic healing can be greatly impeded by wearing a splint because its design is never good.
Yeah, for sure. Can DTR stop headaches?
Of course.
My jaws weren't sore and tight. I always have this horrible tight,
Tension.
just terrible misery. My teeth hurt. Can't chew gum. Can't chew on ice. Nothing because my teeth hurt too bad. And my jaws immediately quit hurting. And by that next day, all of my occipital headaches were gone
Really?
and have not been back.
So the past week you've been headache free?
I have some lower neck stuff that's, I think, residual spasm. But yeah, all my headache per se is gone.
So my experience depends on the kind of headache, what the symptoms are like. At least a third of the time, the people walk back in at recall months later for a checkup and a cleaning, and they no longer have the headaches they used to have before we did that for them.
Yes.
Great. It's absolutely amazing, the difference.
Can you describe it for me?
I no longer wake up with a headache. I don't wake up with neck stiffness. I don't have tightness in the back of my neck, like I want to keep snapping it, like it's so
Yeah.
tight. Have had none of those symptoms.
I'm not going to say this is a cure for all headaches. It's not. But when they're talking about the temporal region, around the joint itself, sometimes behind the eye, suboccipital, back of the head, underneath the ear, that type of location, in my experience, it's a candidate.
Yes, if the headache is in this part of the head, this part, the side of the head, temporal region, there's no question there's a tooth component to it.
Yeah.
It may not be the only component,
Right.
but very often it's the primary component.
And if it's the only component, DTR will knock it out. That's my experience.
Yes, yes.
If it is not knocked out, there's something else going on, something vascular, hormonal, or gosh knows what.
Right.
What can DTR do for the patient and what can't it do for the patient? I think that's a pretty important statement, something we need to address. Pretty important question.
Well, it treats muscular issues, and muscular issues related to the muscles of mastication and those supportive other muscles that we mentioned earlier, some in the ear, some in the palate, and some under here. But it won't fix, a perforated disc, a completely displaced disc. It won't, cure internal derangements, avascular necrosis, bone-to-bone contact. It can't fix those things.
The true intracapsular issues, the real pathologies, something that's, you have some chronic inflammatory response. No, it's not going to help, in my experience.
Yes.
Right?
It treats the muscle problems, which fortunately for most patients make up
That's usually
their
what it
entire
is.
condition. 85% of the people who have TMJ problems have
It's a muscular issue.
primary muscular component. So this therapy really helps the vast majority of the patients out there. And of course, there'll be some that have joint complications that it won't be able to help.
Sure. Let's talk about common symptoms that a patient that is most probably amenable to DTR therapy might experience. In my experience, they have trouble chewing gum. Their teeth will be hypersensitive. They'll tend to stick their tongue between their front teeth. They'll be stiff in the face. They'll have tension in their temporal region. What do you think? Is that consistent?
Similar, they'll talk about morning jaw stiffness, morning jaw tightness. They'll describe getting tired eating. Gum chewing is often something they've stopped doing.
Right.
And I always ask, so why did you stop? Some will
Get
say,
tired.
well, I just don't like the taste of chewing gum. But most say, it just hurts. I get tired. It hurts my jaw.
Yeah.
So I stopped. Headaches in and around the eyes are a common description. Non-organic earaches. No one can find anything wrong with their ear. Tightness under here. Sometimes people say their throat feels like it's closing up. That's because there are palatal muscles that are affected by the lung disclusion as well. So chewing fatigue, headaches in and around the eyes, morning jaw pain, clenching and grinding habits, a sense of tightness in the face, an inability to relax the face. Those are the common symptoms. And then there can be added on to it neck tension.
Don't forget, sometimes you see the hypertrophied muscles, like the temporalis. You'll watch them clench and they'll bulge. It's almost like they're flexing their bicep.
Yes.
Temporalis, their master.
And some people
that a
will
lot.
say that happened to their face. They'll say, pictures of me years ago, my left side wasn't so full. And if you look at a picture of me now, you see that my face is uneven.
I look like the Hulk.
Well, to some degree. They can also talk about hotness in their face.
Yep.
And people who are often diagnosed with trigeminal neuralgia have what is basically a problem from long disclusion time.
Yeah.
There's not, there's sharp pains that occur out of the blue, which characterize trigeminal neuralgia, have no organic basis, meaning there's no tumors or cysts or something pressing on a nerve. It's usually because their
Long
teeth
disclusion.
are affecting their muscle, yes.
Right.
And so disclusion time reduction can be a very effective treatment for trigeminal neuralgia.
So let's talk about DTR. Why? So the patient can understand, what does it do for them?
It stops the teeth from making extra muscle activity, which goes on in an uncontrolled way by the patient using their teeth. So just by using their teeth, in any function or clenching and grinding, but not because they clench and grind, just any function, chewing, swallowing, putting their teeth together to think, clenching and grinding, they make extra muscle activity that tires out the muscles and
Yeah.
builds lactic acid. When the disclusion time is changed, the teeth no longer make that muscle
Changed,
activity.
reduced, changed, made more efficient.
Reduced
faster.
down to very small,
Yeah.
the timing being very short.
So if we're talking about a machine, top teeth, bottom teeth, when we make it more efficient, faster, that's when the muscles don't have to work so hard.
The,
'Cause they're not
the
rubbing so
friction
much.
doesn't rub as much, and
Right.
the tooth sockets don't compress each other for long periods of time, and that stops the muscles from firing.
Because
and then
excessive
the lactic acid
compression-
can leave.
Right, the excessive compression in the socket is what causes the central nervous system, the brain, to crank up the muscle.
Yes.
So
And that
reduced
system
friction.
is the reduced friction, which is the shortened disclusion time, stops the teeth from compressing each other for too long, which allows the lactic acid to leave instead of the
Building up.
lactic acid to accumulate.
And the lactic acid is like when you work out super hard, the next day you are sore. That's a lactic acid burn.
Yes, well, during the exercise, that's the lactic
Right,
acid
during
burn.
exercise. So
Right.
imagine we do this in our jaw muscles, but we work out every day excessively, and we never get a chance to go away. That is the genesis of most muscular TMD pain.
Yes,
And
And-
DTR addresses that
yes.
by making the muscle more efficient, not having to work so hard, and reducing the lactic acid output.
And then the lactic acid can leave,
Right.
be cleared away. And because it gets cleared away, then the symptoms go away.
And we either remove slightly in the back and or add to the front, because the front teeth need to take more of a load than the back teeth essentially to speed things up.
Right. And that's the difference in advocated theory about how teeth should operate. It's always advocated that back teeth should
Yeah.
take much more
This
force.
is not equilibration,
Right.
and
Well,
that's what they're doing.
right.
Yep.
Increasing back tooth contact will increase molar compression in the socket, which will increase the degree of friction, which will increase the amount of muscle activity, which will increase the amount of lactic acid pooling.
Right.
And that's why alternative forms of bite adjustment, which are not disclusion time reduction, haven't been able to show the kinds of results that disclusion time reduction has been able to show. Because it unloads the back teeth. And that is what stops the compressions of the tooth socket, and that's what stops the lactic acid buildup, and then the symptoms go away.
If one were to Google occlusal adjustment, grinding on teeth, one will typically find the National Institutes of Health recommending, they have a policy whereby they recommend that dentists not grind on patients' teeth. What do you think of that hands-off policy?
Well, it's an applicable policy if you're not going to do a disclusion time reduction procedure.
I think it's totally appropriate if you don't know what you're doing, and if you're not timing it, if you're not using objective metrics.
Yes, if it's
I
done
think
by eye.
totally appropriate.
Yeah.
But I think it totally is not appropriate when we are actually watching muscle fire and we understand how we can control it and we can reduce the friction. And by reducing the friction, reduce the hyperactive muscle. I don't think it applies. But I'm glad they got it.
Well, it applies
That
to
principle.
the non-measured occlusal adjustment procedure.
Right.
And-
Most
and-
dentists won't make an adjustment. They're scared. And they
Because
should
they've
be.
been told this.
Well,
you
and
know,
they've
to
made
not do it.
mistakes. They've made mistakes.
Yes.
They've seen it in their practice career where they made a swipe or two and then somebody started having problems.
Yes, because they didn't know what they were adjusting.
Right.
They thought they were adjusting the right place. It's again, looking at the paper marks and choosing incorrectly versus knowing
Mm-hmm.
which ones to choose.
I had a phone call about a year ago from a dentist out in California, and he was probably 32, 35-ish. I don't remember his exact age. I think he told me he was 7 years out of school. And he was dating another dentist, a female. And long story short, a periodontist had done some surgery on this female, and he had adjusted the canine occlusion. He ground down the canine. And he was in tears talking about how he was begging for me to describe how to do this for her, how to fix her. And I basically told him, I can't, I have to see. I'll describe to you the principles. But my point is, there's an example of someone that's supposed to be a specialist in dental medicine that didn't understand what you cannot touch.
Or didn't know what to touch correctly. You know.
And this poor guy was literally in tears talking to me.
Yes.
So we're not educated when we get out of school. This is not something that I was taught in school.
Well, the NIH policy applies to occlusal equilibration. That's
Right.
all that they base their study, their policy on studies that were presented to them only showed research that involved occlusal equilibration.
And the equilibration studies involve just the paper.
The
The
paper
articulating paper, which
and
is 12%
what they adjusted.
accurate.
They did not adjust, as we talked about
Right.
earlier, working side group function is the worst muscle activator. Those studies only adjusted centric relation and balancing side contact, which means that they didn't treat the primary muscle activator. They left it in place.
Which, by the way, is,
Which is working side teeth, molars on the...
and we're taught in dental school that the balancing side incites more muscular hyperactivity, but they're wrong.
Correct.
And I totally see what your research showed. I see that in practice every day.
Yes.
The working interferences incite more muscular hyperactivity. Basically, the side when you're grinding to, back teeth rub, that's working, makes things spastic.
Yes.
I see it all the time on EMG.
So in those studies that the NIH used to make this policy decision upon were incompletely performed occlusal adjustment processes, didn't treat the primary problem.
Right.
People didn't get better, and they said, well, then it doesn't work. But what they were, and they discounted the teeth as being primary, which is why if you read that policy, the last treatment to do prior to surgery might be to do a bite adjustment,
Last resort.
to stay away from it unless nothing else palliative works.
Right.
But what we see every day is that palliative therapy doesn't work at all.
Right.
And disclusion time reduction,
Palliative therapy being splints,
splints,
meds,
massage, psychotherapy,
right,
biofeedback,
right.
laser therapy, never works. And if it does work, it requires repeated effort. The beauty of disclusion time reduction is you do it, it's done, you don't have to do it again, it's self-limiting, the patient doesn't have to do anything, take anything, see anybody, basically resolves
Basically a
the
cure.
issue. It's very curative.
A curative
But the NIH
treatment
policy
for muscular TMD.
was not based on anything that had to do with measured occlusal adjusting.
Right.
Nothing to do with disclusion time reduction at all. Those papers
Sure.
were not included in the literature.
Well, in all fairness, I think it's a good idea for them to have that policy for those people that don't do measured occlusal adjustment procedures.
That's true.
I think that's very fair.
Yes, it's wise.
I think they need to have a caveat, though, that states if one perhaps is qualified and understands occlusion to the point that we do, and we use objective metrics, that I don't know how you get that out there. There's not enough of us.
Well, computer-guided occlusal adjusting is far more precise and far more reliable.
Well,
because
common
there is
sense.
no guessing.
Computers or abacus?
Right.
I mean, which is more accurate? Which is more efficient?
It's not even close. The degree of precision that one can achieve using T-scan guided occlusal adjustment procedures for any process, delivering an implant bridge for, inserting veneers or treating TMJ
Yep.
is incredibly more precise and incredibly more refined than someone basically guessing at the paper marks and choosing what they think they should be adjusting rather than what should
Reading
be.
the tea leaves.
It's
That's what I
essentially
call it.
reading the tea leaves.
Yeah.